Welcome back to the exam room, the podcast where we explore ideas that improve patient care, strengthen healthcare teams, and create better healthcare experiences for everyone. I'm your host, Dr. Rhiannon Winsor. Today we're stepping outside the exam room to talk about something that doesn't usually appear in the patient's chart, but often determines whether a care plan succeeds. Every day, providers make important decisions based on a brief office visit, but patients return home to environments, families, challenges, and priorities that may never appear in their medical record. What if we could understand that part of the story? Joining us today is Christina Owen, a patient advocate who serves as the bridge between patients, families, and providers. Her work reminds us that great healthcare begins by seeing the whole person. Christina, thank you so much for being with us today. How are you?
I'm doing very well. Thank you for having me.
Oh, I'm so excited to get into this conversation. Maybe we could start with you telling us a little bit about what inspired you to become a patient advocate.
Okay, well, I guess over my career, I kind of noticed that there were gaps in care where the provider was really just not getting a good, clear view of what the patient actually looked like outside of their medical chart. So, I kind of felt like that was important to start to educate the patients about their medical conditions and about their medications and about the ask from their provider, then going in and allowing them to actually advocate for themselves more than anything.
Can you tell us a little bit more about your role as a patient advocate, a day in the life kind of thing?
So I guess it kind of all starts with going in and knowing the patient, looking at them from their home life, looking at them as an individual person holistically, understanding them as a whole person, understanding their social determinants of health, understanding their health literacy, understanding their social support, really just understanding them as a whole person so that you can educate them where they need to be educated on, support them where they need to be supported, and then therefore patient advocacy just comes naturally when you give them the tools that they need to go into an appointment or speak to their provider to essentially understand about themselves and advocate for themselves. And then I would just be there to support them. So I'm more of a supportive patient advocate than anything, because I think when we have the information that we need, we can advocate for ourselves.
Absolutely. So, how do you get connected with these patients that you're caring for?
Typically, I will get referrals from the community. So it's either people that I've helped before, somebody that they know needs my help, or a family member needs my help. I also get referrals from community social workers as well. There are gaps in the healthcare system. Inside of value-based care, we understand that there's gaps inside the system that need to be filled. And in not all areas of healthcare are they doing that right now. And so medical social workers are seeing needs for patients who need to have time, who need to have someone who can actually sit down, hold space, and take time with that person to understand the person as a whole. So my referrals really come from any community source, is where my referrals come from. Social workers, chaplains, community health workers, prior clients, prior patients,
Mm-hmm.
family members, really anywhere. I don't get my referrals directly from the hospital or doctor's offices.
Okay, so you don't have the patient's chart. No.
No, ma'am. No, ma'am. I am going in completely blind. I understand the patient's environment. I'm looking more at the social side of things, right? Not necessarily the medical side of things as in a medical chart.
Yeah.
But you would be very surprised if you step back and you look at somebody from their social side of things, where you're going into their homes, You are looking at the support that is provided to them by their community members. You are looking at their home life. You are looking at their resources. You are looking at those F codes. So we're looking at those, mental diseases that kind of affect people's ability to be compliant. And you're looking at those things and you're stepping back. So I go in blind, right? I go in blind and I meet the person where they are. I sit down and I listen to what is most important to them first. Once I realize to what's really affecting them inside of their health and inside of their life and what matters most to them, then I'm able to say, all right, well, it sounds like, weakness is really affecting you, right? Or shortness of breath is really affecting you, or these symptoms of chronic conditions or terminal conditions, I can actually see what they're complaining about. And then that's my end, right? So then I'm able to look at their medications because I am a nurse. I am a registered nurse. So I am able to do disease management education. I am able to do that under my scope of practice. And so I'll go in and do that and then ask them for their medications. Love, love, love a bottles out medication reconciliation in a home. Like that's my favorite thing to do because providers are not able to actually do that. Right? So they don't have the time to do it. So, here's your prescription, here's your prescription, here's your prescription. And you have no insight on the patient's ability to carry out what you're asking them to do. So the bottles out medication reconciliation to me is my favorite thing to do because they'll give me their bags of medications. And when I say bags of medications, that's literally what I mean. They've just went to the pharmacy. They're on Medicaid, right? People are on Medicaid, so they're getting free medications. Anything that the doctor prescribes for them, they have in their home. They're on Medicare. They're paying, a low cost to things. And so they have these bags of medications. And then I take the medications out and put them on the table. And I put them out on the table according to the disease chronic condition, right? Hypertension, diabetes. So I actually can look at a table of medications and know what diagnoses the provider has given to them. The patient has to have an ICD-10 to get a medication. You have to have a diagnosis to get a medication. So I don't have to look at a medical chart. All I have to do is look at the bags and bags of medications. So then you step back and you say, hey, what are you actually taking here? And typically, very few that I come across are being compliant with medications. And those that I do come across who are being compliant with these medications are typically having a side effect from the prescribing cascade, right? We're prescribing one and then we're prescribing another for a symptom and then we're prescribing another one for a symptom. And so those who are being compliant, I'm seeing which medications are actually causing the issue. Number one, we're starting from number one. This is the medication that's causing an issue, but you're being prescribed this one, and this one because this one's causing a problem. So we need to go and talk to your doctor about this medication being a problem. All right. So you give them that information so that they can actually go talk to their provider about that. And then those who are not being non-compliant at all and they have a symptom, you say, okay, well, this is the medication that is for your symptom. Your doctor's already prescribed it. I'm not prescribing a medication, but I'm actually encouraging compliance of a medication that would help a patient. That's how I do it. That's what I do without a medical chart. Thank you, prescribers.
Yes. And I think it can get so confusing for the patient over time. I know with one of my family members that has some chronic conditions, it's like, okay, we'll put you on this medication and then back for another visit. Okay, don't take that medication anymore, or take half of it, or take double of it. And then there's all of these bottles at home that they're not taking anymore, but then could get mixed in with what they're supposed to be taking now. Literally a list with like, scratch this out and write this underneath it. No, you're not taking this anymore, and that's, oh, for the patient can be very confusing, frustrating, detrimental.
Overwhelming and a way in for noncompliance.
For sure. How long have you been filling the role of patient advocate?
So I would say going into my third year just as a community patient advocate. So this would be in a way of a nurse by license. So I've been doing it for quite a while, over, nearly 2 decades. I've been doing it as a nurse. So nurses
Mm-hmm.
are patient advocates naturally. And so in the last going on 3 years, I've just been kind of a lay community advocate. And I don't know that it would even be called a lay community advocate, so because I'm still advocating as a nurse too, because I'm still practicing under my nursing license as well. So so for 3 years, I've kind of been doing it in the community within my nonprofit, just helping these people understand chronic conditions, terminal conditions, medications that they're being asked to do, how to navigate a system that we can't really navigate anymore. So this provider and this provider and this provider and this provider, which is the beauty of an ACO, right? Because then we don't have to we don't have to go from provider to provider to provider anymore. So yeah, bravo for ACOs on that.
Yes,
Yeah.
here, here. So you've been advocating for patients your entire career.
Mm-hmm.
What do you see in your experience that providers often miss during a typical visit?
The patient.
I don't want to hear that.
So I think that they miss what matters most to the patient. They miss what matters most to the patient because I think when they go in to a visit, they have about 10 to 15 minutes. Really, not even that, maybe 10 minutes, depending on how double booked they are at the moment. And they are looking at a medical chart. They're not looking at and this is just my experience being a patient advocate in a room, right? So this is where patient advocates can kind of turn things around because you cause pause.
Mm.
When you're in a room with a patient and they have no idea who you are and you're just kind of sitting in a corner, it causes them to pause. And they have to say, wait a minute, what's going on here? The patient really kind of starts talking about what matters most to them, and then they have to pause. But I think that providers could do it better if they would just pause and figure out what matters most to the patient instead of their check marks that they need to check off to talk about the chronic conditions. I know I need to talk about this hypertension. I know I need to talk to, congestive heart failure management. I need to talk about diabetes management. I need to talk about your medication list. I need to talk about your symptoms and what new medication I need to prescribe. And so if they could just stop for a minute and say, what's going on with you? What matters most to you today? And so I think that's how we could do it a little bit better.
Mhm. I love that. I love that. What matters most to you? Everybody wants to share what matters most to them,
Of course they do.
and it feels like that's connection, right? Which is kind of the core of patient engagement. Is that connection, that trust, rapport building. Can you share a story with us about a patient who really changed the way you think about healthcare?
So I'm just going to mention one little lady, 94 years old, having symptoms from a prescribing cascade, being prescribed medications that may not necessarily be appropriate for a 95-year-old lady, and coming in again from a community referral blind, walking into the lady's house, and she's 94 years old and she's exhausted
Mm.
and she's having falls and her blood pressure is so low that she really has no cardiac output. And this is because she is one of our compliant patients with medications, very compliant. And so I was able to go in there and educate her about side effects of medications and how they were affecting her well-being, how they were affecting how she felt. And she was having home PT, home physical therapy. She had some home health, home physical therapy, and the physical therapist, of course, could not do things with her because her blood pressure was too low. So when I come in and I say, we got to get to the doctor, this is not something that we can wait on anymore. You don't feel well. You're not performing well in physical therapy. And we truly need to get to your doctor's office. So the daughter-in-law made an appointment with the cardiologist, and we were able to go into the cardiologist's office within 2 days. So within 48 hours. And we go in, and of course, the daughter-in-law is in there, and the patient is in there, and I'm kind of in the corner. I always position myself in the corner because I'm the least in the room and I don't need to be seen first and foremost. Like, I need to be the last person seen in the room. But of course, a provider is going to notice an extra person in the room who's not been there before. They're also going to notice when a patient starts talking about things that they've never talked about before, and they're using words like polypharmacy in an elderly
Mm,
adult, or I don't feel well because of possibly this medication, and you've given them the education on their disease, their chronic condition. You've given them their education on the side effects of these medications, and then it makes the doctor pause. And these visits typically turn from 10 minutes to 45 minutes, and this happens repeatedly when I do my patient advocacy work inside of doctors' offices. And then the doctor pauses, and then they start to deprescribe. They start to figure out truly what the patient needs to be on. They deprescribe, and the patient goes out not only feeling better that day because the provider has listened to them, but feeling better because they're on proper medications.
mhm,
And so I think that cases like that, and it was just so hard for me to think of one because I have many that are like that, right? And so it does make me feel a little bit different about our system because we are just pushing people through to get them
mhm,
through, get them all seen. And there are providers out there who truly are pausing and listening to their patients and taking their time when they have someone there. Either they know their information, or they have someone there who is causing for a pause. And I think more than anything, it's important for the patients to understand their chronic conditions
mhm,
and their
mhm,
terminal conditions and their medications, because that alone could eliminate the need for patient advocacy,
mm.
truly. As if people were educated enough. And I know, Dr. Windsor, you guys are getting some programs together too, to educate patients about their chronic conditions and their medications and things like that. And that will change the game in the healthcare system. I really think that.
Yes, I think education is definitely a key component. I mean, I've been in healthcare and education for almost 30 years, so I'm a cheerleader for both, bringing both together, so I'm really excited to be able to launch our patient ed pilot and see how that goes.
Yeah.
So these experiences, like the one that you just mentioned, how do you think that's changed your approach to patient care?
It's caused me to pause.
Mhm.
It makes me look back to say, okay, in your 27-year career, when did you not take a pause? When did you just need to go in and get a task completed, or educate about something, right? I'm looking at a disease process and I am passionate about education. There's been many times that I've gone into a situation where this patient has congestive heart failure. Love this one. Congestive heart failure, fluid overloaded, taking in a lot of salt, things that I need to go in and educate about. And I'm going in and I'm full force educating about it. And I didn't pause to see that maybe they didn't understand that their food has the sodium in it, or they don't have the money to purchase appropriate food for this disease management, or they don't have a way to the store, or all of the social determinants of health that affect what we're actually the ask the ask of
Mm.
the provider, or the ask of the person going in to talk to the person. Like, we're not pausing to see if they're able to carry out the ask. I feel like that has truly changed me, as I know I needed to pause when I was going in to educate them about what I wanted to educate them about. What wasn't, what was important to them wasn't what was important to me, you know? So seeing the person holistically and understanding what is important to that person.
Yeah, so
Yeah.
that's a conversation my CEO and I have had a lot of times about, okay, what motivates someone to learn?
Yeah.
It varies so much, right, from person to person. And we kind of go around and around with each other where, I think I've kind of got it boiled down to, as adults, what motivates us to learn is a problem that we need a solution to.
We want to feel well.
Yeah.
Everybody wants to feel well.
Yeah, absolutely. So, as we're wrapping up this segment, one last question for you here. If a provider wanted to begin looking beyond the chart tomorrow, what's one thing they could start doing differently?
I'm going to go back to the same thing. Pause and find what matters to that person. What's most important to the person in front of you? Don't worry about your check marks, because I can promise you that your check marks are going to be filled if you
Mm,
truly just stop and look at that person holistically as an individual and what matters most to them.
absolutely. That's a game changer, right? Because if you can figure out what's most important to them, the rest of the conversation can be connected back to that core thing
Yes,
that the
yes.
patient just said, you know, seeing my daughter give birth to my grandchild, that's the most important thing to me. Okay, we can have that whole conversation through the lens of that motivator.
What's going to get you there?
Yeah.
What disease process are we, what chronic condition are we trying to manage here to get you there?
That's it for this episode of The Exam Room. But our conversation with Christina Owen doesn't stop there. In the next episode, we'll take a closer look at what happens when we step outside the doctor's office and see the world our patients are actually living in. Christina shares what home visits have taught her about health literacy, medication management, and the barriers that can make following a care plan much harder than it looks on paper. We'll also talk about a conversation that isn't always easy, but can make a tremendous difference for patients and their families: advanced care planning. And in the episodes that follow, we'll explore the communication gaps between patients and providers, the role a patient advocate can play in bridging those gaps, and what Christina says her patients have taught her throughout her career. So if you want to hear more about what it really means to see the whole patient, not just the chart, join us for the next episode of The Exam Room.